The next speaker is Dr. Emanuela Gakidou. She is currently an associate professor of global health and director of education and training at the Institute for Health Metrics and Evaluation at the University of Washington. She also leads the Institute's research activities in the area of evaluations. But before joining IHME, she was a part of the Harvard family. She was a research associate at the Harvard Initiative for Global Health and the Institute for Quantitative Social Science, and I'm proud to claim as well that she was also part of WHO. She worked as a health economist in WHO, where she led the work on measurement of health inequalities. So in her work in IHME, she has been spending some time in Zambia, and she will be talking about what are the actual results on the ground in Zambia. Emanuela.
Thank you very much, Tessa. It's good to be home. I've actually spent 12 years here, so, and it's also good to be at home with WHO colleagues. So thank you very much for the invitation. It's a pleasure for me to talk about something different than a lot of you are familiar with my inequality work. But of course, inequality isn't everything I do. So I'll just show you my take on equity and universal health coverage based on my recent work in Zambia. So I have a bunch of maps and a lot of graphs in this presentation and almost no words, but I'm going to approach the question from 3 different perspectives. So first, we're going to spend some time on population level trends in burden of disease and coverage of key interventions. So that's sort of like looking at the population level, what's happening in Zambia. Then we're going to go to provision and take a facility level perspective for a little bit. And then in the end, we'll look at the patient level and try and bring it all together. So bear with me through a series of maps and graphs. A little bit of an overview. We're a bit south from Rwanda. I didn't actually put the map of Africa, but just a little bit south of Rwanda. Huge population growth between 1990 and 2010. There are about 13 million Zambians right now. A fair amount of economic growth. GDP per capita is still at about $1,500 per person per year in international dollars. You'll note a big improvement in education, especially the education of women of reproductive age over a 20-year period, which is quite remarkable and has also had a big effect on child and maternal health. And if we look at what's happening in life expectancy, it went from 50 years to about 56 in 2010, but there was a big dip around 2000 at the height of the HIV epidemic, and it's come back up. And child mortality has gone from about 180 per 1,000 to about 105 in recent times. So a lot of progress in economics and education and in some key health indicators. This is a picture of all the deaths that happened in Zambia in 2010, split by age and by cause. So the age groups over here span from birth to age 5, and then each 5-year age group goes over there. The big yellow is not going to surprise anybody, HIV/AIDS. Then we have diarrhea, malaria, and then nutritional deficiencies. So part of why I'm showing this is to emphasize a point that is well known. Most of the deaths happen before the age of 5. A lot of them are infectious diseases. So for the remainder of this presentation, partially because it's imperative to talk about the majority of the deaths, and partially because we have a lot more data on child health than we do on adult health. So I'm not going to pretend that the only reason I'm talking about child health is because it's important, but it's also where we have most of the data. So we're going to focus on the under 5s for the next few minutes. So these are the trends in the top 20 causes of death between 1990 on the left and 2010 on the right. And if you can read some of this, that's great. What's really impressive is that not much has changed in terms of the composition of the top 5 causes of child death. So we have in 2010 malaria, HIV/AIDS, malnutrition, pneumonia, and diarrhea. that were all among the top 5 in 1990. Some of them have shown dramatic decreases. So malnutrition has improved by 40%, but it's still among the top 5 causes. Malaria, there's only been a change of about 10% over the 20-year period. And if you go further down the list, you'll also see that the condition profile of the population under 5 has not really changed much in a 20-year period. So the same challenges that the Zambian health system was facing 20 years ago, they're facing now. They're at a different magnitude, but it's still largely the same conditions. Now, if we look at what has actually happened to under 5 mortality, this graph obviously shows a huge improvement over a 20-year period, going from close to 180 per thousand down to about 100. And then this is not meant to be a comprehensive view of the health system or everything that has happened in Zambia over the 20-year period, but it does include some major initiatives from the government and the Ministry of Health and international agencies that provided funding. So some notable ones are a decentralization health sector reform that happened in the 90s, followed by the implementation of Child Health Week towards the late 90s. And then as we get to the 2000s, we see PMTCT, a lot of malaria interventions scaling up. And then recently, the government has invested in human resources and infrastructure restructuring within the health system. So when we look at the progress over the 20-year period, it's really difficult to attribute it to an action of one organization or another, or one intervention or another, because collectively, a lot of things have been happening in Zambia over the 20-year period. We take a look at select child interventions and maternal health interventions that influence child mortality in the 20-year period. We see a very heterogeneous picture. So in red, we have one visit of antenatal care, which seems to be flat and at a high level. But this orange line is 4 antenatal care visits, which started out about 70% and has dropped by almost 50% in a 20-year period. Skilled birth attendance is this light blue line staying flat. This is immunizations, DTP3. And who would like to guess what this huge, massive scale-up is? Bed nets. Somebody said bed nets. So see a dramatic increase in bed nets. There was almost no bed net ownership before 2000, and they're now at about 70% nationally. If I had data on PMTCT, the graph would actually look quite similar to bed nets. So there's been very dramatic scale-ups in ownership of bed nets, PMTCT, and ARVs in the country in the past decade. So this is what's happening at the national level, and from now on I'm going to shift to looking at the subnational level, because even though the country is not huge, there are 72 districts and a lot of heterogeneity throughout the districts. So you're going to see a series of slides like this that have maps. In all the maps, green is good and red is bad. So the scale tells you the exact magnitude, but I've kept the same colors theme throughout the slides. So again, this is Zambia. Lusaka, the capital, is here. Copperbelt province, which is one of the more affluent regions, is over here. And in general, Luapula and the eastern provinces are not doing so well off. If you look over time, the map of under 5 mortality is getting greener, which is good. We saw a huge improvement. We also see the green spreading throughout the country, but there are some regions that are still not doing as well as others. The reason why districts are important in Zambia is because the district health system, the medical health team at the district level, is where policies get implemented. So the Minister of Health actually has the ability to do something at the district level. So let's move from mortality and look at coverage of interventions. This is DTP3 immunization, so 3 doses of DTP by the right age. We don't see a whole lot of change over time. We saw that the line was pretty flat at the national level. But throughout the country, there are some districts that were not doing so well 10 years ago that are doing better, and some districts that remain as problem areas for the government to implement what should be routine immunization that they should be delivering to every child, especially after the implementation of Child Health Weeks twice a year. looking at a very different intervention. This is scale up of ITN ownership. So almost nobody had bed nets in 2000, and pretty much there's bed nets in every single district in 2010. So what this actually shows us is that it is possible in a very short period of time to have a massive scale up of an intervention and have it spread throughout the country. It is actually feasible. If we had the map of PMTCT and ARV, it would look very similar to that. However, owning a bed net is not sufficient. So this is a map of ownership, and this is a map of use. What I would actually like to have is a map that shows averted child deaths or morbidity episodes because of the ITNs. But even this map difference tells a very compelling story. So just because they're able to get the bed nets out into all the districts, that's clearly not sufficient. There's huge variation in the uptake of the intervention and people actually using the bed nets in their home. And this is a place where, in discussions with the Ministry of Health, they're actually intervening. So they have identified districts that have high ownership and low use, and they are actually working to improve this. But just another demonstration that giving out intervention is not sufficient, and it has to be followed up with subsequent actions from the government. Now, this is a very busy slide, but one way to look at progress over time is to compare different interventions and over time. So this is immunization, this is 4 visits of antenatal care, and this is stillbirth attendance compared to what happens in the country on under 5 mortality. So we saw that under 5 mortality, the country gets progressively greener. That's great. DTP3, there's not a whole lot going on. More or less things are staying the same. If you look at ANC4, so women that actually get 4 visits during pregnancy, the country is getting redder, and it's all over the country. So they have a massive problem of, even though women show up once for antenatal care, they don't go back for repeat visits. And then skilled birth attendance is getting a little bit better over time, but it's pretty stagnant. Not much is happening. We know that these are important determinants of under 5 mortality, and yet under 5 mortality is getting better in the face of a massive decline of ANC4 and in the face of not many improvements in skilled birth attendance. So something somewhere is going right, but it's not the routine healthcare system. Let's see what happens to education of women of reproductive age. Back in 2000, the majority of districts were in red, which is about 2 to 3 years of education. And 10 years later, we have a lot more districts in green, which is closer to 8 years of education. So the spread in education has actually geographically gone to most of the country, with a few of the more remote areas in the north and the northeast, and then the western province still lagging behind. If we look at malnutrition, another key determinant of under 5 mortality, we also see actually significant progress in the 10-year period, with a lot of areas that had a high proportion of children that were malnourished, doing a lot better 10 years later. So again, looking at this at the same time, we look at education, malnutrition, and under 5 mortality. These 3 seem to be moving more along the same lines across districts, and I'm not going to make any causal claims here or anything even remotely close to that, but the health system's interventions were moving in different directions than under 5 mortality. Education and malnutrition are moving in similar directions, so perhaps there may be a contribution of improvements in the education of women and in the malnutrition status of children that have led to these improvements in under 5 mortality. So we're going to switch gears for a little bit. I'm going to show you some data from the facility level in terms of what's happening at the provision of care. I don't have these data at the district level, so I have to split facilities by different types. So I commented that there was a massive scale-up of PMTCT and ARTs. At the facility level, this is seen as a massive increase in the number of visits, the number of people that show up at the health facilities to receive ARTs. So the red line is hospitals in rural areas. The purple line is hospitals in urban areas. The green line is health clinics in urban areas. And the blue line is health clinics in rural areas. So this graph shows a massive increase between 2006 and 2010 in the number of ART visits per year across health facilities, with most of the patients receiving care in hospitals and the clinics showing a lower volume of care, with the urban clinics actually seeing a moderate amount. Now, there has been a lot of discussion about the scale-up of ART and what that may have resulted in unintended consequences for the rest of the health system. So one way to approach the question is to ask, well, what happened to other services? So not the provision of ART, but what were these facilities providing at the same time? So this graph shows trends in outpatient visits and inpatient visits for the same group of facilities over the same time period. And largely, the trends are flat with a little bit of an increase. So this leads me to think that the increase in the number of ART visits did not take away visits that were going to either outpatients or inpatients. So it didn't come as a substitution. It was on top of whatever the facilities were providing. They also started providing a lot more ART care. There's also an argument that perhaps what has happened is all the resources have been concentrated to facilities that provide ART care, and so the facilities that don't provide HIV/AIDS services have had fewer resources and therefore are doing worse off. So another way to look at it is to look at the volume of care produced by facilities that have HIV services versus those that do not. So the red line is hospitals that provide HIV/AIDS services, and this line in purple is hospitals that do not. The blue line is clinics that provide HIV services, and the green line is those that do not. And again, we see a flat, slightly increasing line. So there is no evidence that the massive scale-up of ART has actually taken resources away from other routine care that hospitals and health centers were providing, at least in these data, which was very reassuring because it has been a big concern in Zambia. So the last thing I want to mention is what do the customers say? Right? So all this is great, but what do people say about their experience with the health system? So we did patient satisfaction surveys across 100-something facilities in Zambia. And one thing that was noteworthy was that in the more rural health clinics, we would spend about 3 days there and not be able to get more than 5 or 6 exit interviews. So there is still a large number of facilities with very, very low volume of patients. So I'm not showing you data from facilities that have fewer than 30 exit interviews. But there is still a great challenge with facilities that are staffed and where patients do not show up. So in terms of what people say about the average travel time to urban and rural health facilities, the axis here is in minutes. These two bars are for urban facilities, and these two bars are for rural facilities. And on the left is people that have less than primary school education. On the right is people with more than primary school education. And this is 60 minutes. This is about 75 minutes. So we see that the more educated you are, the less your travel time to a facility, both in urban and rural areas. So this may have to do with geographic proximity or with the access to a transportation mechanism that is more efficient. Then we asked how long do you wait to see a provider, and there's many different ways to look at that data, but what I'm showing here is the proportion of patients that wait over an hour to see a health provider in urban and in rural facilities, and again by education. So this is urban, this is rural. The left side is people without primary education. The right-hand side is people with more than primary education. And we see that about 55% of people in urban areas without primary education have to wait more than an hour to see a provider. And that goes down to almost about 40% of people in a rural facility and urban facilities with more education. So yes, there is a difference, there is an inequality between people with education, with higher education compared to lower education, and how much they wait. But overall, the wait times are really long. So even in the best case scenario, 40% of people are waiting over an hour to see a healthcare provider. And again, this is self-reported, so people may be exaggerated, but what really matters here is the perception of people if you want them to keep coming back for care when they need it. So then we also asked an overall patient satisfaction question. So on a scale of 1 to 10, how satisfied people were with the care they received upon exiting the facility. This is for urban facilities and this for rural facilities. So overall, we're at about a 6 or a 7, which we can't really interpret because it's really hard to compare the scale from Zambia with other countries. But there is a difference between urban facilities and rural facilities, and the facilities that do the worst are the Ministry of Health hospitals in more remote areas. The facilities that do the best are the Ministry of Health hospitals in urban areas. So it's not that the Ministry of Health hospitals are bad. There's some difference between urban and rural area, at least in how people perceive it. And really what we wanted to know is, would you actually come back to the facility if you needed care? And in this graph, red is no, so very few people say no. But we really would like everybody to say yes. And a lot of people are kind of ambivalent, especially in the rural Ministry of Health hospitals. So again, these are self-reported data with all the measurement issues associated with it. But if you're trying to answer the question, what can you do to get more people to the health facilities, improve utilization of services, and seek care when you need it, this is helpful input. So I'm going to leave you with the map of the actual burden of disease in Zambia in 2010. This is what the government is facing right now. In red is the communicable disease burden, in blue is the non-communicable disease burden, green is injuries. So they have a health profile of largely infectious diseases, HIV, malaria, huge, but malnutrition is also still very big. Pneumonia and diarrhea are also still very big, neonatal conditions. And they're in a setting where the government spends about as much on healthcare as they get in development assistance for health. So in this context and in the context of the burden of disease, does universal health coverage mean more efforts in HIV, TB, and malaria than have been seen today? They've been pretty successful at scaling up. How exactly should they be addressing the remaining burden of disease to both shrink the size of this box but also shift from communicable diseases to non-communicable diseases? So, thank you very much.